Yes, Lord, appreciate you bringing us all together today. Help us do the best work we can to keep our nation strong. Lord, we try to serve you the best we can, and we know it's hard. It's like serving the nation. It's very hard to keep things straight, but we all care about the nation or we wouldn't be here. So help us in this venture. Amen.
Amen.
Amen. Thank you.
Mary Baker Shaw. Mike Dobbins.
Here.
Bill England.
Honey.
Keith Austin. Harley Buzzard.
Here.
Joe Bird.
Honey.
Sean Crittenden.
Here.
Shannon Duncan. Wanda Hatfield. Rex Jordan.
Here.
Dave Lay. Mike Shambaugh.
Here.
Leo Smith.
Here.
Denise Taylor. Victoria Vasquez.
Honey.
David Walkingstick. Brian Warner.
Honey.
We have a quorum.
Thank you. Thank you very much. Has everybody read the minutes? Anybody want to make a motion to approve them? Second? Second. All those in favor say aye. Aye. Okay, reports. George, are you here with us today?
How are you? Gary Lane.
Gary?
Yeah.
Hi, Gary. How are you today?
Mr. Bowyer apologizes for not making another month. Had something else come up, so he sent me in his stead. So greetings from Claremore. As far as our staffing goes, we're still down a general surgeon and one midwife. We do have one other nurse practitioner opening in our clinic that looks like we're going to hire the locums that's been serving there. So we really only have these two positions open. Our outpatient visits are up 3.6% over the same time period last year, and our revenues are up 24.7% over the same time period. Our ER remodel, we are really close. We're really close to getting that open. We're still hoping to get it open before the end of the month. Construction's done. There's just a few contractor checkout items that we have to get resolved before we take possession of it. Our outpatient visits are up 3.6%. Dental visits are down 7.9%. Admissions down a little bit, 12.3%. And our newborns are down 5.6%. It looks like we're still going to be reaching over 300 deliveries for the year. Collections, overall, our May collections are at $2.2 million. Year to date, they're at $20.8 million. And our collections are up compared to our fiscal year 2018 for the same time period by $4 million. PRC activities, we funded 379 cases this month, 200 of which were Cherokee Nation citizens. We had 479 denials, 368 deferred cases.
Wonderful report. Does anyone have any questions? Yes, Councilor Buzzard.
Yes, I know, Board had talked about the remodel on the ER.
Mm-hmm.
Can you just explain a little bit what you've done? And it's been a long time since I've
Okay.
been back.
Well, our existing ER space, we've still been using it. It will stay the same. We're adding 4 exam rooms to the south of the ER. I don't know if you've ever been to Claremore. There's the south back door that goes in the emergency room. There were some storage spaces back there. So we've added 4 new exam rooms.
Making a total of how many?
Huh?
Making a total of how many?
4. There are 6 in the hall. 1 across the hall with 3 beds, and we have the big room that has 4 beds.
Okay.
And on the other side of that hallway, we're adding a registration and waiting room area.
Okay.
So when you come into the ER, instead of having to go through the ER and into the main lobby, now we're going to be registering those patients there, getting them in the waiting room there so they can get in and screen much faster.
Good, I'm glad to hear that, 'cause, I've used Claremore before. On those
Any
bases.
of you are in the area, come by, because we'd love to show that space off.
I will, I'll make it a point to come by. Thank you. Thank you, Madam Chair.
Anyone else with any questions? Gary, can I ask you a question? How far out do you all schedule your patient appointments?
Depends on the clinic. As far as the adult medicine clinic, usually we schedule them out at least a month, and I know our established care appointments are out a couple months. Surgery clinic are out 4 to 6 months. Audiology is out a couple of months, so it really depends on the clinic.
Do you have any idea how far you schedule out on your dental appointments?
No, I don't right off the top of my head, but we could look and get back with you on that.
I would just be curious to know that.
Okay.
Anybody else? Gary, it was a great report, and tell George hello for us, okay?
All right. Thank you very much.
Thank you. Now, Cherokee Nation Health Service, Dr. Steve Jones. Good afternoon, Dr. Jones.
Good afternoon. Thank you for having me. So we'll talk a little bit about the report that was included in your packets. I'm not going to read it to you, just point out a few things that are usually questions so we can emphasize those. And I think earlier today, Counselor Dobbins had pointed out our vacancy rate. You can see on page 3 there of the report, 5.3% currently, against a benchmark of 25% for IHS. Another benchmark is in the private sector for our region is around 12 to 14%. So we're doing pretty good at retaining and filling our vacancies. The other one is the referral approval rate. You'll see that we're 97.1% approved. Usually those ones that fall in that 2.9% there are going through some type of appeals process. So but currently for this month that we're reporting, 97.1% of the contract health referrals were approved. Last month you asked me a question, Counselor Buzzard, about if those reported visits included pharmacy, and the only thing it does not include is dental, because everything that's in Cerner it does include if it creates a patient visits or a FIN number. So if it creates a number as coming in for pharmacy, coming in for physical therapy, anything like lab, then it's going to be counted in those numbers.
Okay, everything but dental, right?
Everything but dental, because dental's in a different electronic record.
All right.
So, okay, and that's why we report it separately on your deal too.
Yeah.
Trends, you can see everything on, if you look at the next to last page, you can see most things are either trending the same or up, a little slight decrease at Salina, but everything else is trending up on services delivered. The other question I was asked last week I wanted to clarify too is on J, the new versus refills on prescriptions. We looked into that. There's been a workaround that they've been using to do medication reconciliation, which is causing the refills to be recorded as new prescriptions. So there was a process that we've had to correct with our providers on how they're recording that to flip that around. The other part of that number is the fact that we're fully staffed there at J. So that has increased the number of prescriptions also. Some of those are in fact new prescriptions, but there is a workaround. You'll see that number decrease as we've educated people on how to do it correctly. But it was creating a new prescription when in fact they were just discontinuing the old one and refilling with a new one.
I see, because I had followed that for several months and I noticed that. Okay, I'll keep an eye on it.
Yeah,
All right,
but
thank you.
you should see it. Now this is, we'd already talked about it when this one was, because we're always a month behind on our reporting, but you should start to see those numbers change over.
All right.
The other thing that I want to talk about is our joint venture building, the outpatient clinic there in Tahlequah. The reason it took a little while to get the responses back to you, I usually get those back within 10 days, but this time it took a little longer. We were on a push to get beneficial occupancy before July 1st, so it took a lot of our administrative folks and a lot of other folks outside of health to get that done, and we did accomplish that. And got beneficial occupancy as of the 18th or 19th of June. So we hit it a little bit ahead of time, which ended up meaning that we got some funding that we would not have been able to get had we not been able to achieve that. So the next push is to get us there for September 30th now. So so we get out of out of one situation into the next, and we're working hard to do that. It has enabled us to get some transition things moving a little faster. So our staff is going through different types of exercises for a day. We call it a day in the life, what it's going to look like when we get over into the new facility, how patients will be routed, how staff will route patients, how we'll communicate with one another, and we're going through those exercises now for the transition. That's all I have to report.
Wonderful. Any questions? Counselor Crittenden?
Yes, doctor. I had someone in the business of the health field there. Had some questions, and we talked about it a little bit. And I was going to ask you to please define what are elective procedure referrals.
Elective procedure referrals? Okay, I'll have to get you a list of those, but anything that's would be considered elective. A knee replacement may be considered elective. It may not, depending on the situation. Eye surgery could be considered elective, depending on the medical necessity of it. So there's different types and different layers to that. It's not simple as this is an elective surgery, this isn't. So cosmetic surgery is an elective surgery.
Right.
Those aren't covered. So there are different things that fall under different categories and different levels of those categories on what's elective and not.
So you do have a list?
I don't have a list per se, but I'm sure we can come up with something that would give you some
I'd like-
guidance. But typically, those are decided through our committee. And
No, that was my next question. Who determines what is elective?
Well, that they go through a system of what is approved and what is not approved initially, and I guess it would be an algorithm, and then those that don't automatically fit into the approved status, then they are reviewed to see if they should be approved or not. And at that point, if it is chosen not to be approved, then there's an appeal process that will go to a different medical personnel that will look at that and see if they feel like it should be overturned or not.
No, that's all in-house. People
That's all
looking
in-house,
at.
yeah.
And the committee, does Contract Health have their own
It's made up of medical doctors.
doctors, and they'll decide
Right.
whether it's elective or not? But yeah, I'd like to see just a general list of, what, and maybe some scenarios of, like you were talking, the eyes. This would not be elective, and this probably would be. And they, another one. So if a person is uninsured, what is the process for elective or not elective? If they're uninsured, because they're getting down to a question. Any patient, are patients asked to take an insurance plan out that may have a cost for a procedure? Are patients asked to take out?
Anytime that we have contract health monies being spent, the Cherokee Nation is the payer of last resort. Okay, so if they are not covered by insurance or not covered by a third-party payer, we ask them to meet with one of our counselors and see if there's a way we can get them covered so that we can pay what's left that's not covered. So they're not under obligation to take any of those plans. Sometimes we can get a plan that is no cost to the patient. Sometimes it's like Medicaid, sometimes just simply getting them signed up.
Right.
And then that saves us contract health dollars to be able to spend them down the road.
Right, and
So-
anybody can understand that. Let me just ask you, let's say they couldn't find a plan and there were some cost. Do we make them do that and not serve them?
If it's a medical necessity, no. We always pick up the cost. If we refer somebody out and it's medical necessity, then we're going to pick up that cost. There's no cost to the patient. But in some cases, patients have found that they could get full medical insurance for less than $20 a month, and they choose to do it. We don't pay that premium, but they have the option of doing that.
Medical necessity, that would be different than an elective.
Yeah, different than elective.
Because there could be a plan out there that could help them.
Right.
And if it's an elective, they're not necessarily going to get the service without maybe taking out one of these plans.
Right, and maybe the service is completely paid for under one of those plans. So, there's different plans for different individuals, and it's all it's very convoluted, and I can't speak to the details of it, but it's, in that marketplace, there's 100 plans, you know.
One last one pertaining to this. If a person has Medicare Part A only because they cannot afford Part B, what is the process for them not having Part B? They only have A. Is it similar to what we just talked about?
Yeah, that would be something that I would have to check into and see the specific situation, because everything is, those things are very, there's a lot of regulations that go along with getting someone signed up on the different parts.
And that probably boils down to, whatever you can or cannot afford.
Yeah.
Bottom line is, if it's a necessity, it's going to get taken care of.
Right.
Also, I've got to ask you, where are we on Stillwell Clinic? I mean, today, where are we at?
I didn't check into it before I came in. I know that we've signed the contracts for the trailers to be put in place. We came to a amount to spend on what we thought was fair for leases for those trailers. I know the taps have been done. We've paid the city for those taps, so I haven't been over there to check and see if they've delivered the trailers yet or not, but that's the step we're in right now. We've met with the architects and we've gotten through the redesign of the front of the building to allow elders and handicapped patients to be able to park. I think we end up getting between 25 and 35 extra parking spots up on the same level as the clinic. That took some time to redesign that because the civil engineering that's required to get rid of the water, because we are landlocked and we don't want to put water on our neighbors. So those things have been done now, and we're at that point where the trailers should be delivered. At that point, we'll start certifying them to get ready to move the robot from the pharmacy into the trailer and make sure that we have everything secure and they get certified by the state. Once that happens, then we can start the transition and moving.
Now, and of course, you don't know, but do you foresee the trailers getting set up? And I'm not pointing a finger at you, but we talked about those trailers and taps for the last couple of months.
Yeah.
You see that probably in a month?
Some of that is out of our control, but some of it has been. One of the things was the flood setting back some of the work that was needed to be done, because the same contractors that will be delivering those trailers and doing the dirt work there were getting pulled away for other jobs. So to my knowledge, the last time that I met with our folks, they were in the process. I know personally I signed off on the PO for the trailers, so I know that those checks are being cut or have been cut. That was 2 weeks ago. So I know we're at that phase. I just don't know delivery dates and when the transition will start occurring. And again, I told you also we were looking for a place to park our employees, because once we start making this transition and we start staging the demolition of the old part of the building, part of the parking lot goes away. And so we have to have a place to allow our patients to still park, but we're going to have to transition our employees and transfer them back and forth from wherever we find. And so far, the closest place we've found is up at
C&I.
that is actually reasonable. We
Yeah.
had a couple other areas, but they were
That's
mud, and in wintertime, when it starts getting bad, you're not going to want to have people parking their cars out in the mud. in the field.
Yeah, that's just growing pains. I mean, nobody likes to get hauled back and forth, but if it means getting that together.
Trying to come up with a vehicle that will transport them and having some type of schedule, so if someone's kid gets sick at school, they're able to get them back to their car, to get them to their school. I mean, there's a lot of logistics to work out to keep everybody happy, so.
Well, I look forward to next month. And Madam Chair, I was going to let you start the discussion whenever you're ready about our dental meeting, everything. So,
I think Counselor Dobbins is
okay.
going to discuss
We
that.
can do that whenever. I would just.
Counselor Dobbins, would you like to discuss that at this time?
Well, I'm sure a lot of you have heard phone calls from constituents kind of frustrated with the dental appointment procedure. Keep in mind, this is just for new patients. Now, if you have constituents that are patients already, they've been examined, even they've had their treatment completed, they're placed on a 6-month recall. We may be maybe the only tribe in America that has a recall system. But we're still kind of looking for, I think the dental staff has done the best at this point to figure out a way to get new patients scheduled. And right now, there's just a window every day at 4:30, and we can only take X number of new patient exams every day. And then at all our clinics, our doctors, I could be corrected, but I think all our doctors do 4 new patient exams a day. And that's all they can do. We can't have our doctors just doing patient exams all day. They could, but they have to do treatment. And but anyway, Chairman Shaw has asked me to look at other models that might be able we could use to improve our system of new patient scheduling. But I think right now the dental staff, they've tried different things, and this seems to work the best, although it may not be perfect. But I will look into other alternatives to see if it could be doable in our system.
I would like to add my thanks to you, Dr. Jones, for arranging that meeting. Counselor Dobbins, Counselor Crittenden, and myself did attend, and it was very informative. I mean, to sit down and hear what the dental clinic is dealing with and the staff, it was very informative. And hopefully, we can come up maybe with some alternative suggestions or something. And I really appreciate Counselor Dobbins investigating that. But again, thank you for setting that up.
Sure.
Appreciate it. Yes, Counselor Crittenden.
Just to follow up, and I know the transition to the new building, that's gonna help out a lot, seating, and I wasn't sold yet on the 4:30 call-in is the best thing, simply because I get so many calls about it. And I've been in on a few of those. I was teacher's assistant on our break. We had 3 phones out one time, trying to get in. But once the transition takes place, it'll be interesting to see just how much that helps, with the more chairs. And so I'm not a fan of the 4:30 deal, but I'm gonna give it a chance to get switched over to the big building and see how that goes.
Well, we're also going to be expanding our dental services in Stillwell. We're going from a 12 to a 16-chair clinic, so we're getting an increase in the number of chairs and the number of providers there also. So we're trying to take the pressure off of the system. But right now, with that clinic being closed, the limited amount of chairs we have at Hastings, it's not a perfect system, but it works right now, and it's gotten our no-show rate way down. So it doesn't do any good to schedule the patients if the patients don't show up. Then we have a provider that's sitting there with an empty slot. So it's the best that we have right now.
Let me ask one more question on that. Like the new patients, that's the 4:30 folks. Now, like a teeth cleaning, is that a walk-in?
Not usually. In some cases, it can occur if you're a walk-in on a day whenever things are a little bit, not as busy, and if you're a patient that's looking to get into our system for a denture or for a partial, because those patients will be ultimately referred out for that service. If there's something we can do while they're there to get them through the system quicker, then they will do that. Now, it doesn't always happen, but if a hygienist or a dentist has an opening because someone didn't show up and there's a walk-in that has that need, they will put them in their chair and get it done. But it doesn't always happen that way.
So they would be a part of the call-in too, then?
In most cases. Now, if for example, it's a diabetic patient, then we prioritize and get those people. We have certain days where they'll do diabetic exams, and we try to get those patients scheduled and get them in as quickly as we can, because we recognize that that's a serious issue when they can't eat properly and they have diabetes. So.
All right. Thank you.
Sure.
Thank you.
Speaker Byrd?
Yes, with the injection of the joint venture, we've got our first drawdown, I think. Those funds are used for operation and new hires, is that correct?
For hiring and some equipment. Yeah.
Okay.
So
For equipment as
yeah.
well.
So operational things, but right now we're trying to utilize that money to get staff on and get them trained before as we go through this transition, of course. So there's a lot of new people showing up and not a lot of space to put them in right now, but we're trying to get people identified who we need up front. For example, as we get areas of that building turned over to us, we've got to go in and do a clean, get it up to standards to be able to see patients, because they turn it over to us with the construction cleaning, which, as if you've ever been involved with construction, is not detailed cleaning. So we have to identify those people. We've been hiring those people and getting them trained so they can go into the facility and start the cleaning process, and that's been going on for about a month.
Thank you, Madam Chair. Keep up the good work, Dr. Jones.
Thank you.
Anyone else have any questions? Dr. Jones, there's been a lot of discussion in this past week about raises and salaries. Are we competitive with the salaries that our healthcare professionals are currently being paid?
We're looking into that. I've got several projects working, 37 I think, currently, and one of them is looking at compensation, not only at our physicians, but at our nurses at different levels, at all different levels of our health system. So, but that's something we do jointly with HR. And as we move through this, it can't all be done at once. We've got to do it a little at a time, and we've got to see what the budget impact is, and then present that budget to you guys to approve or disapprove. So we're working through those things now. We're looking at whether our compensation package is good or not. We feel like right now, with our vacancy rate the way it is, that in some areas we need to work a little harder, in some areas we're doing okay.
I hope you would know that I think council could be very supportive of ensuring that we, retain the best qualified people in their positions. I just want to make sure that we are comparable to what's being offered in other places to retain those if that's what it takes.
And I agree totally with that, but I also agree on the back side of that there has to be some accountability.
Exactly.
And there has to be some expectations on what we get for that amount of money that we pay. In other systems, we're looking at how they model those things, and we'll be coming with some recommendations soon.
One thing I do want to share with council is that one thing I admire so much about Dr. Jones is he has held our employees to be accountable. And I for one, is very grateful on that. It's resulted in some very needed changes, and I personally am grateful that you have done that.
Thank you.
A couple of questions. Do we utilize insulin pumps?
I can't answer that for sure. I don't know the answer to that, but I can find out.
Okay, thank you. And then over the weekend, we had a CCO conference, and I had several at-large citizens with some questions, and I want to thank Dr. Montgomery in specific for being available to help me and assist me in some of these, and I'm grateful for that. I have a question that I got to thinking about. Do we have a form or something when an at-large citizen needs to be referred? Is there a form where they may sign something to let them know they will be responsible for any charges outside of our health system?
And they're being referred for medical.
For something medical?
They've come to us as a beneficiary, and they are being referred out.
Right.
If it's something that, my understanding of that is if we refer them out, and Steve may be able to correct me if I'm wrong, but if we refer them out, then we're going to take care of that responsibility.
I don't believe that is correct.
If it's
Is that
an elective, something's elective, it may not be. But if it's something that we're seeing them for and we're referring them for that service, then my understanding is that we're paying for that. But I can ask that for sure. Not at large. Okay. So I'm mistaken.
Yeah, not at large. My suggestion is quite simple. Could we, or I don't know if we do have a form, but a form to let that person, that Cherokee citizen, know that they will be responsible for those charges if they follow through with that referral. I find that to be quite a common occurrence with our at-large citizens. They don't seem to understand that they will be responsible for those charges. And I think if you had them sign something and give them something that states they will be, I think that could eliminate a lot of misconceptions.
Do we have a process now that we do that with? So certainly we'll look at that and try to get that process fixed.
I think that would be very beneficial for everyone. Yes, Councilor
Good.
Crittenden?
How are we on time? We okay?
Yeah.
1:30. We got till.
We got time.
Another thing, Doctor, I was going to ask you about is and it's a problem we talked about a few years back, is the people that they're going to get their bill paid, but it's going to the credit companies, and they're really concerned about that. Did we ever devise a letter? We talked about that when Connie was here. Some sort of letter that could ease these people's mind, plus the creditors. What's the discussions you've had about that? Because I get lots of calls. I'm sure everybody does hey, the credit people are calling us, collections.
Well, I don't know if we have a letter yet. I'll have to check on that and see. Steve, can you speak to that? Do we have a letter?
We do have something we send out that acknowledges the death of Cherokee Nation, and we are working on processing that payment to not make the bid back to the person's credit. So we do have something we send out once we acknowledge it is our bill.
How are we informing the patients themselves? Because can we do better on saying, hey, look, now you're going to get denied maybe, but we send it in again and then the creditors start coming. Can we inform the patient better?
They keep us pretty informed when they get those bills. They're pretty quick to call us and say, we got a bill, we're about to turn it into, and they get those in our hands immediately. We can look at improving that process.
And I appreciate Mr. Carey. Just he's really done a good job, and just I can't think of a situation that he hadn't helped me with. Madam Chair, I'm going to ask you a question here. We recognize lots of people here. We recognize lots of people. And I've got a couple, Mr. and Miss Rocky Carroll. Good. I met them at a gospel singing. Just real fine people. They're not complainers. They're not going to, say anything out of line. I talked to Councilor Shambaugh about it, but if I may, can I have 5 minutes? Mr. Carroll has some concerns, and he's right here, and I'd sure love it if he could, maybe some suggestions to us. This is not a point fingers at Mr. Carey. Like I said, he's helped me with this, but Rocky was visiting with me, and I know Councilor Shambaugh, and he's got some pretty good points, and it might help some of us. Just a few minutes. Would that be okay?
Councilor Crittenden, may I suggest that you all meet after this meeting? Be happy to volunteer, my office even, but to discuss that and see if we can get it in writing.
Right. Mr. Carey, would you mind to visit with us a little bit? And you've got it's on paper, Rocky? Okay, yeah, and I can get it to them.
Dick's first.
And, we'll do it that way, so don't run off. We'll meet right here. Thank you guys for coming. Thank you.
Thank you.
And I want to say one more
Counselor-
thing about that. Sometimes it's educating the entity that we refer to itself, because they have turnovers. They have office managers that turn over, and educating them on how to get the bill back to us to be paid. The easy way is to turn it over to collections.
The medical facility that we refer
That
to.
we're referring to, and if they have a turnover, and we found that before where they have a turnover and then they send that bill to collections instead of sending it back to us, because they see the patient's name on it rather than Cherokee Nation as the payer. So sometimes it's as simple as getting back with them and re-educating their office manager on how to correctly do the paperwork to get the bill paid. So I have found that several times has happened.
Councilor Lake, did you have a question?
Yes, ma'am. Thank you. Doc, a lot of the times, at least in my district, when we have those bills that start filing up to a collection agency, sometimes I feel like, some ball is dropped somewhere and I don't know where. It may be what you were just saying. The patients themselves keep telling this collection agency, I don't owe you that, subscribe over that. And so until it gets to a certain point of pressure, and so then they start calling either you or me probably, or the clinic. And only then, 6 months later, we're trying to figure out why we didn't pay. And so I'm not sure what process takes place. You were explaining a process there in that.
And sometimes it's the difference in inpatient and outpatient. So if it's inpatient and it's in the area of Claremore's operations, then it has to go through them first before we can touch it.
Well,
And if it's outpatient, then we can.
I'll
But
debate that with you a little bit. They're denied at Claremore almost automatically. They come to us and we say we're paying for it through the telephone committee. And so sometimes we still don't pay, but I think it's a ball is dropped somewhere, and it may be on the other end. I always wondered where it was at, but nobody can tell you that. But anyways, I don't know if there's an additional step you guys could add to the process, or an additional piece of paperwork saying, call this, used to be Brett Hayes, call this number, I'll use his name, he's not here to defend himself. Call this number for help and assistance in paying that.
And
Because it usually goes about 6 months, and these people are mad by the time they call me. And we said we'd pay it, but we didn't, because something fell through.
right. And sometimes, like I said, it's as simple as the contractor, the provider we're contracting with, not doing the appropriate paperwork to send back for payment. It's all outlined to them when they enter into a contract with us. But sometimes they don't take the time to read that, and they sign off on it, and then we have to educate them after the fact. So
They're
that
not
happens a
smart
lot.
enough to get paid.
That happens a lot. They assume that the way that normal billing takes place by billing the patient would take care of it, but that's not the case with us, because we don't require our patients to pay for that.
The other thing on compensation, several years ago, we had a committee on compensation. You were here, but not in your presence.
Right.
And I look back and I see a couple of guys, I think, who were here then also. And if what you're telling me is correct, shouldn't there always be a rotating compensation committee judging as to what, if we're keeping up with the Joneses, if you will?
Well, there is
Paying all these docs?
there's a thing called MGMA standards, which are put out by the Medical Association. I'm assuming, I don't know who publishes that, but it is the standards by which most entities use to look at their compensation in their region. And so those things are done independently and objectively, and then you have to take those and apply them to your system and see how they fit into your system.
So are we reinventing the wheel every couple of years, or we,
I think initially,
from what I heard, it seems like we are.
I think initially there was an attempt to reinvent the wheel, so we're looking at how everyone else does it and trying to modify that into our system.
Thank you.
Counselor Smith?
I just want to say, in the last 3 months, I've had 8 cases, and they've been real good to work with me. On some of them, they were turned down the first time, and it was on the paperwork, and we went back and then make a call, and within 2 to 3 days, we had the problem solved, and the people that had the noses were happy, and I just thought it was a good job. To me, it seemed like y'all got on it real fast, and I had 8 cases, and I documented them all and everything, so did a good job. We had that one hard lady, but it wasn't our fault. Thank you.
Counselor Shambo?
On the billing, I think the big problem is, it's the late bills that come in, because sometimes all your bills come in, but then that 2 months later, you seem to get that $500 bill for whatever reason, or 3 months later, and that doesn't get addressed, and for whatever reason, it probably doesn't get turned in, or the people assume that the hospital sent it to us, and I think that's the biggest reason why we get dinged, or people get dinged a lot, is those 3 month late bills, and they don't get sent to you guys. That's been my take on it. But what I was really wanting to tell you is, I was at the J Clinic. It's been several months ago, and I'm sorry I didn't bring it to your attention, and I think it was, she was given a certificate, but I was coming out of the clinic, and there was an elderly man coming up, and the parking at the J Clinic is horrible. They have to walk so far. The handicap parking is quite a ways away. I don't know if there's anything can be done with that, or move it to where they can come in closer to the back. But he would walk about 10 yards and stop, 10 yards and stop, and I actually went out there and talked to him and asked him if he wanted me to get him a wheelchair. And he said, no, it's good exercise, I'm good. So I kind of stood in my truck and watched him for a little bit. Well, a nurse came, or actually, she works a behavioral health clerk, came out and brought him a wheelchair and wheeled him in, and he was very, very appreciative of that. I think he was just a little too proud to ask for one.
Yeah.
But her name was Brenda Larson, and she went above and beyond to come out. She said she noticed him having trouble, and she went and got a wheelchair from her office and went and got him, and I just thought that was a pretty neat deal. So,
Great. We'll make sure we acknowledge that.
Okay, any other questions for Dr. Jones? Dr. Jones, thank you so much for coming today. We appreciate it. Appreciate your reports. Thank you. I really appreciate how you answer our questions. Thank you. Okay, next we have elder care. Thelma Pittman, I believe Connie Davis is here as well. Good afternoon, ladies.
Good afternoon.
We missed you last month. Glad to see you here today.
We apologize.
Oh, you can't help
We
the-
had an
you
we had
can't
an audit
help-
going on, and
Yes,
we
you
apologize the leeway from the council.
You did. Would you like to
So I
start?
believe you have the report submitted for the month. Just a little bit of an update from that. We're up to 180 participants, which is an all-time high for an elder care program. And I have a couple being enrolled this month. Things are perking along well. We were under construction when I first started the contract in March for administrative building. These ladies and gentlemen have been working out of a mobile home for 10 years and literally had holes in the floor. So they're very excited to be in the new facility, and it's operating very well. I'm excited about that. And it's paid for, as I understand.
Yes,
That's-
completely paid for. So we paid as we went. The building itself came in around $123 a square foot. So we're real proud of that number, that we got it down that low. The only thing that we have left, I'm working with Five Star on the furnishings, and we estimated around $25,000 for new furnishing for 11 workspaces. I pushed it up to 14, and we're going to have to pay another $1,300 for an additional 3 workspaces. So we did real well on the furnishings also.
Where's this construction taking place, if I may ask?
It's on our site at Elder Care.
It's right behind the formal building.
And you have a design for that somewhere that we could see?
Yes, sir, I can get that to you.
Okay.
As soon as we get some art from Gino Lea's helping us with some art for the hallways and conference room, we'll have an open house and have you guys come out and take a look at the new facility.
Okay.
I can email you the floor plan though, if you
Okay.
would
Mel,
like that.
will you do that to Gail, would you please?
Sure.
The other exciting news is when I served on the board, in my other role, we had talked about expansion and the need to go to other zip codes. That's how we serve people, based on need. And we're excited to be able to begin the process of expanding into Muskogee next. And we're hoping to maybe use some property at Three Rivers to build on. The highway access is good and will allow us to get close to Sequoia County. And I don't have the specific zip codes because we haven't even started the application process, but we are doing that. We have to secure a location, an address, and then we'll be working on feasibility and official document submission, hopefully within the year.
Will it be within the 14 counties?
Muskogee, yes. Yes.
Okay.
Within the 14. Anybody have any questions they'd like to ask these ladies? Yes, Counselor Buzzard.
And that was the question I was going to ask about, were there any more policies or procedures to develop more of these PACE centers? I think when this initially started, we had looked at maybe doing 6 PACE centers throughout the Cherokee Nation 14 county jurisdiction. But now that you mentioned it, Connie, I want to make sure some of our zip codes are on that study north of 412, because we certainly need something out there. I know the nursing home business is not the best up there. We certainly need a facility kind of like we have here in California, so make sure that you look at some zip code north too.
Looks like Rogers County, maybe in the Pryor area, would be the next place for us to strategically go.
And you just mentioned those names right now. They sound like they're more populated areas. Don't forget the rural areas. We do not have access to ambulances, hospitals, those things like that, and we seem to get overlooked about everything like this. Rogers County, I'm not taking anything away from Rogers County, but that's a pretty populated county. Look at Delaware County, it's not that populated, so we don't have an ambulance service. So those need to be taken into consideration when we look at things, so please do that.
Absolutely.
Thank you, Madam Chair.
Counselor Austin.
In response to the Rogers County, North Rogers County, there's the northeast part of Rogers County, I'd say quadrant, has, it's 20 minutes to get to anybody there. That is not an area with services. Clamwild Branch does, but there's a big area there without services. So it's kind of a big brush.
This is the whole county in Delaware County.
Yeah.
Counselor Dobbins?
Thank you, Madam Chair. How many constituents you say you serve?
I think about 46% we've identified as eligible.
How many total do you serve? Was you say 180?
Yes.
Well, there's 180 participants, but 46% of those are native, and 51% right now are non-native. So, but that fluctuates, Councilman, it usually sits around 50-50 on constituents.
And you have 68 employees?
Yes, sir. And 70% are native and 30% are non-native.
I apologize, I'm not as informed as I should be. Can you kind of tell me what Cherokee Elder Care basically provides, what kind of services?
Yes, sir. We are have a full-blown clinic. If they need a specialty service, we send them out for specialty. We pay for ambulance, we pay for inpatient, we pay for their meds. It's a program that has been within the Federal Registry for almost 30 years now. There's 126 PACE sites in the United States. We were the first PACE site to be sponsored by an Indian nation. We still are the first one to be sponsored by an Indian nation. We've been here almost 12 years. Well, I've been here 12 years. We will have our 11th anniversary in August. And whatever their needs are, we have occupational therapy and physical therapy on site. We have 18 of our participants in nursing homes that we provide for. Some of them are in assisted living. Whatever their needs are, we provide those needs. We have an interdisciplinary team that looks into their needs and their services. We provide DME, hospital beds for homes if they need a hospital bed for rehab. We are a full-blown service for our participants.
So if they're homebound, you go to the home.
We have contracts with home health agencies, Cherokee Nation Home Health, and several others that we send aides into the home to help our participants. Yes, sir.
Counselor Crittenden?
Yes, ma'am, we talked about this last month. I just want to make sure I got this in my old feeble brain here.
Yes, sir.
Like the building that's being constructed.
Mm-hmm.
Now that's no Cherokee dollars,
No,
right?
sir. No,
None of those employees are paid by the nation.
no, sir.
And so, now when you say sponsor, what do you mean?
Every PACE center usually has a sponsor, especially a rural PACE center. In the beginning, as Councilman Buzzard said, there was a feasibility study, and actually they wanted 4 PACE sites within the 14-county area. Cherokee Nation did sponsor the dollars to get started and to construct the first facility, which we made monthly payments back to Cherokee Nation Business to pay off that loan. And Medicare and Medicaid, we are subsidized by them.
Yeah, when you see that word elder, and
Yes, sir.
I see your vehicles out, it's just a win for everybody.
Yes, sir.
But in my position, some people think that you have to listen to me. Some people think you have to listen to the chief, but in all actuality, it's not Cherokee Nation, right? It's a separate.
We are an agency of the Cherokee Nation within the executive branch of the Cherokee Nation. We are an agency. So we have contracts with risk management. We pay for our insurance, just like I think the Housing Authority does, and those type things. But we're an agency within the nation, but we exist on federal dollars.
And the board is appointed by.
By the chief and vetted by your council.
All right, I think I got it now.
Okay.
Thank you.
I have a question. You all are operating at a loss, if I'm not mistaken, of almost $500,000 this year. Who covers your loss?
We do.
You do?
Yes, ma'am.
Okay. And one other question. How many inquiries are there daily, if you can give me an estimate, of people wanting elder care services?
It has increased. Some days it's 2, some days it's 20. It just depends on if somebody sees our van or if they see our newsletter or those kind of things. So it varies, Chairman.
Varies daily, but there absolutely is a need for you all to actually be larger, actually. So
Yes, ma'am.
The
There
need
is
for
a
the new
need.
clinic, that's awesome.
Councilman Lay asked me last time about Tulsa County, and I hope you got the information that I gave to Mr. Enlow to forward to you, Councilman Lay.
I do Tulsa, Washington, no water, Rogers.
Yeah,
I'm interested in all those. I know you can only move so fast. I understand.
right. And,
But we'd
well,
love to have you.
I know, we'd
Tell us
love
what
to
you
be
need,
there.
We'll get it for you.
Life Senior Services in Tulsa covers, and it's a PACE facility, and it's federally subsidized as we are, and they would entertain native as well as non-native, and I wanted you to understand that, and also Broken Arrow, they're expanded to Broken Arrow also. So,
When you tell me your percentage of native and non-native on who you serve, that's impressive to me, and that's something that I think that you would continue the further out you go.
yes, sir. But I wanted to make sure that you had the information.
Thank you.
Okay, any other questions? Okay, thank you all so much for being here today, we appreciate it. I'll entertain a motion to adjourn. Second? Aye. Okay, all in favor? Aye.